Please stay muted when you're not speaking. And yeah, if you have any questions, please submit your questions or comments in the chat. The moderator may call on you to ask your question, and this event is being recorded for on-demand access. And just to stay ahead, please make note of our next month's Journal Club on March 11th. This next month's Journal Club will be hosted by SUNY Upstate and University of Rochester. And there are a few spots still open for 2026. So please use the link in the chat to secure your spot for the host. All right. And now I will turn it over to our to University of Maryland's group.
Thanks a lot, Dr. Lee, Dr. Humphreys. Thank you guys for the invitation. Thanks for letting us be here. I apologize for the background noise. I've been in the lobby of a fairly busy hotel since I was down here for a meeting in Miami, but I will do my best to avoid that noise. I'm KJ from University of Maryland, and with me is one of my illustrious first-year fellows, Justin Robbins. He is a superstar. And he's doing a fantastic job for us. And we're going to be speaking about this really interesting paper on a really apropos topic for us, the association of repair timing on outcomes following TVAR or IMH. The reason I say it's apropos for us is we do a lot of dissection work. We do a lot of treatment for IMH. So that's really a nice paper for us to review as it's prepare for. So just a little background: IMH is a life-threatening condition. It's within the confines of acute aortic syndrome. That with dissection and penetrating aortic ulcers. It's usually contained to the aortic wall. It's a hematoma with bleeding into the media, but no discernible intimal black formation. Most of us that take care of this with any frequency see that over time it either absorbs or it progress to an overt aortic dissection and have aortic rupture and other complications associated. And it can occur anywhere along the aortic body, anywhere from the ascending down to descending at the unknown. With that, I will turn it over to Justin so he can go through the paper.
Okay, thank you, Dr. Nagasha. Let me share my slides. All right, can you see that?
We can.
Okay, perfect. So like Dr. Nagasha said, we're going to talk about the association of repair timing on outcomes following thoracic endovascular aortic repair for intramural hematoma by Mancella, Dr. Eagleton, and their group over at Mass Gen. So Dr. Nagasha already talked about intramural hematoma, what it is. So we'll skip past that. The main question for this paper was the SVS does have guidelines regarding recommendations for observation, hypertension control, and then in patients with high-risk features, recommending TVAR in those patients. However, there is still a lot of debate with the Thoracic Society, AHA, and SVS regarding optimal timing for these patients. So this study wanted to look at when is the best time for this group of patients. So it was a retrospective cohort study using VQI data looking from 2013 to 2023, and they looked at patients with IMH who underwent TVAR in zones 2 through 5. They excluded any patients with zone 0 or 1 or beyond zone 5, any patients with penetrating atherosclerotic ulcers, and any patients who presented with rupture or had missing presentation data. They had two groups. They had the urgent TVAR group and the elective TVAR group. Urgent TVAR was within 24 hours of hospital admission, and elective was anything past 24 hours of hospital admission, any patients who had TVAR. There were 345 patients total. 52% or 180 underwent urgent repair, and 48% or 165 underwent elective repair. The primary endpoint was perioperative mortality, death within 30 days or during index hospitalization. The secondary endpoints were postoperative complications such as stroke or AKI, reintervention rates during the index hospitalization, length of stay, and 5-year all-cause mortality. Statistical analysis, they used propensity score weighting to balance baseline characteristics and adjusted values below 0.1 to allow for accurate comparison of timing effect alone logistic regression was then used to compare perioperative outcomes. The baseline characteristics, the only differences that were significant in these groups were the urgent groups had a higher rate of transfer. Patients in the urgent group had a lower beta blocker use, which was defined as beta blockers prior to admission or at the time of admission or perioperative, and for impulse control. And then in the urgent group, there was a higher percentage of symptomatic patients. They evaluated their overall cohort and then they separated and did a sub-analysis of the symptomatic patients. The first one we're going to talk about is the overall cohort. There was no significant difference in landing zones for any of these patients. So when looking at the overall cohort, the perioperative mortality rate was significantly higher in the urgent group, 6.3% versus 0.6%. Reintervention was higher, 8.3% versus 2.4%. However, overall complication, stroke, and AKI were not significantly different. They then looked at the symptomatic subgroup and found, again, the urgent group had a significantly higher perioperative mortality, 7.3% versus 0.8%. AKI was higher in this group, 9% versus 2.5%. Reinterventions were higher in this group. And then total length of stay greater than 14 days was higher in the elective group than the urgent group. The key results that they kind of look at are the perioperative mortality of the 19-fold higher risk in the urgent group of perioperative mortality, 5-fold higher risk of reintervention, the higher risk of AKI in the symptomatic patients, and then they looked at the 5-year survival. And while it wasn't significant, it was lower in the urgent group when looking at the overall cohort and the symptomatic cohorts. So the conclusions were that urgent TVAR is high risk with worse perioperative mortality. Patient stabilization is crucial. Medical management with blood pressure control and impulse suppression should be prioritized. The limitations of this study is the retrospective nature of this study and the inherent biases that come from that, and the inability to look at granular details. The selection bias from the VQA data set, including, there's centers of excellence and that may not represent all practice settings and centers that don't have as much experience with TVAR as these centers who are contributing to the VQI. There's also lack of indication, specific clinical indications for the urgency in the database, so they couldn't substratify on what made it urgent compared or elective in these groups. And then the lack of cause of death information, and then the sample size is relatively small in order to perform subgroup analyses. The take-home message: stabilize first, prioritize medical optimization before TVAR when appropriate. Beta blockers and impulse control are essential, and then consider urgent TVAR only when aortic complications are imminent for these patients. And that is it. Questions?
Thank you, Justin. So I think the paper has a lot of strengths. One, it talks about acute aortic issue that that a lot of us are dealing with more frequently. And question is really, timing. When do we address this? How do we fix this? One of the questions that I've seen someone ask is, will this change your practice? Does this VQI paper change your practice? And that's something we find a lot of question-wise. I mean, we read a lot of papers, and there are a lot of great papers coming out of the VQI database and large database in general, but do they actually change your practice?
Sorry, I'm just a little confused here, and that's my fault for not logging on earlier. Cosmos, are you or Sammy the moderator for this paper?
I am,
Okay,
I
so
think.
yeah, so Sammy, now's a great time for you to open up the conversation with your thoughts about the work, and then you can address those questions. Mohit is here to answer those, and the group from MGH is also here too. So why don't you start with just your thoughts about the paper, and then you can go into discussion with Mohit.
Sure. So I'm Sammy Seattle from Fresno. Great job, Justin. Your presentation was very good. I think you hit the nail on the head towards the end, and that's kind of where I really wanted to focus. It's an important topic, and the treatment of acute aortic syndromes, from penetrating aortic ulcer through IMH and dissections, It's continuously evolving, uncomplicated versus uncomplicated, high risk features, no high risk features. I think the biggest challenge with this paper is that, it uses VQI. And what's the issue with VQI is that it doesn't capture the granular drivers of what leads us to proceed with an open repair or urgent repair, sorry. Things like pain, malperfusion, refractory hypertension, rapid expansion, the high risk features that you mentioned. We don't have any of that information. So we don't really know what prompted these patients to go to the operating room early. So while they did a propensity score match, that adjusts for the baseline comorbidities, it doesn't really adjust for the acuity of the disease process. Going through the data, you can see that patients who were taken urgently, 98% of them were symptomatic, whereas the non-emergent urgent ones were only 72% were symptomatic. You also mentioned that there were no variables mentioning hemodynamic instability, no high-risk imaging features. This is part of the issue with VQI. Your variables that you look at um, are quite limited. So I think the observed mortality difference here probably more reflects the fact that those patients are sicker, not from actual harm from the early intervention. So, claiming that delay improves outcomes, I don't think that's necessarily really supported by the data as it's presented. One of the tables, let me see if I can pull it up the table here. The table that shows the mortality result, if you look closely and you look at the confidence interval, that confidence interval goes from 3 to 764. That's a very unstable model. And the reason that's the case is that the event counts were really low. And furthermore, to add to that, the absolute event counts weren't actually, I couldn't find that anywhere in the paper. So ultimately, while it's helpful to know the timing, the 24-hour, I think, cutoff is somewhat challenging. It's what we have from the VQI. But doing a case immediately and taking the patient to the OR within minutes is different than waiting 6, 8, 12, 18 hours in this potentially rapidly evolving process. So, those are my big thoughts on the paper. I think it's really helpful to kind of keep talking about this stuff because we're still, learning. Intramural hematoma, I think in and of itself is a little less, there's a lot less papers on it compared to dissections, because I think it's far less common. So I think this is still something that we're learning about, and the treatment algorithms are still in evolution.
Sorry, you didn't have any questions for the authors?
Well, yeah, yeah. So my
Okay,
question
sorry.
was, the first one was, does this change your practice? I put it in the chat, so I
Okay.
guess that wasn't clear.
Yeah, no, thank you. Thank you for your questions, Dr. Siad. And just to start, I actually agree with a lot of your perspectives about the paper. I think the challenge that we run into with a lot of these VQI papers is that, I mean, the VQI in general is a great database. It has a lot of data that otherwise wouldn't be as accessible if you're doing these large multi-institutional studies. But like you mentioned, the data just isn't super granular. So when I was writing the discussion for that paper, I was really trying to caution and say that it's we're probably just not able to capture some characteristics of the IMH that drives a patient to have an intervention more urgently rather than something more elective. So to that point, I think as far as the changing practice guidelines, I'm still a medical student, so I still have a lot to learn, of course, here as well. But I would imagine that the emphasis is more so on when clinically appropriate and when the patient's physiologic status warrants it, it's better to go with medical stabilization based on a clinician's judgment and maybe not necessarily rushing to intervention. But again, like you mentioned, it really depends on the characteristics of the IMH that we're just not able to capture with VQI data.
Hey Jay, I'm going to ask you a couple of questions because you do a lot of this work you mentioned. Looking at this, is this in line with the patients you're treating, or do you find that, some of the patients that you see in here, you tend to sway one way or the other towards treatment versus just kind of treating people with just an IMH as they present, even if it's in an urgent fashion?
based on their presentation, that's when we decide whether or not someone's going to get an intervention. Our preference is to wait as long as possible for IMH to allow stability and almost like a fibrosis of the IMH before intervening, just because we find there's a higher risk of dissection and progression to more acute problem. I'd be interested to hear what the other people on the panel have to say about that.
Yeah, I think that's one of the concern or the hard things about this is just really as you're seeing these patients and when is the optimal time. You know, we also we're trying to admit them, we're trying to get their hemodynamics under better control. Sometimes that's the hardest part is getting those patients to where they are getting, you know, having a low blood pressure, low heart rate, but yet they're not getting volume overloaded and they're not having shortness of breath or some other consequences of the medications that we're using. And I would say most of the time when we are pushing to go sooner for IMH, it's one of those two conditions. They have some complication, or, you know, it's the fact that I like to say that our ICU is going to flood these people to death, and then we're going to have a different problem sometimes. And so it's a challenge to get these people controlled occasionally.
The
So I
one
have
thing
another question for you, Mohit, if that's okay. Do we have time?
Absolutely, absolutely.
So first of all, great job as a med student. This is awesome, awesome work. So, you deserve definitely a lot of shout out for that.
Thank you.
Now, going forward, let's say, you could design your ideal paper to look at this issue. How if you didn't have the VQI and you had 5,000 patients at your institution, how would you design your future study potentially?
Yeah, I mean that's something that we put a lot of thought into. I think what it would require is likely a much more in-depth chart review, but at a single institution, which obviously introduces its own biases. But we could likely dive into some imaging characteristics if they were available for these patients, and that way we could address the issue of not having the granular characteristics of the IMH, and probably incorporate some of those variables into the model that might address any confounders that dictate whether a patient undergoes urgent versus elective TVAR.
What is the practice paradigm at your institution for these kinds of, if you can answer that question?
Yeah, I'm not 100% familiar, but
That's all
I
right.
don't know if anybody from the MGH group can answer, but
No worries. Congrats on all your hard work.
I appreciate it. Thank you.
I am curious about just general, maybe Dr. Nagasheth can answer some of these questions. When you intervene on IMH, kind of what is your treatment protocol? Because the one thing I am a little puzzled about from this paper is that the treatment zones are limited from zone 2 to zone 5, which is expected. But if you look at the distribution of the extent of the disease, there's 4% of patients or 5% of the patients that are in zone 0 IMH. And I can't ever recall doing a TVAR for a zone 0 IMH, which is essentially an ascending. It's just something that cardiac surgery should be intervening on.
Yeah, so we have just like a lot of places, we have a fairly robust relationship with cardiac surgeon. And so if they are at zone 0 in the ascending or something like that, we tend to involve them very early. And many of them are going to get kind of what we say cool down with impulse control before taking them to the OR, but they are getting, for the majority of them, getting operative intervention for zone 0. For the type Bs, like zone 2 through distal, we're going to try to do impulse control as much as possible to try to control their symptoms. And then we will usually, I'd say in the majority of cases, we are intervening on them within the first 2 weeks. We are taking them for a TVAR during that index hospitalization with fluorine patients.
Yeah, it's interesting because I would say that most of the zone zero stuff that we do is because our cardiothoracic surgeons, there's some other reason that they don't want to operate on that patient, be it, some of them are older and frail. There are a bunch of different reasons that they'll push back a little bit, and their answer is always, well, can't you figure something out? Can't you make something with a stent or do something? And of course, we're vascular. We can make anything we want, is what I usually say. Sure, we can make that for you. KJ, your question about the hypertension, I think is something I was kind of reiterating or discussing before. We have found in a lot of these patients that you try to drive down their blood pressure and they're on all of these medications, and then their renal function starts to become an issue. And so that is where, as I was saying, our SICU team or our intensive care unit team, they become so focused on the creatinine that they will just flood them with fluids because they're concerned about the renal dysfunction. And sometimes that will push us because I get into this circular pattern of my intensivists not necessarily feeling comfortable with us going forward, and the renal insufficiency or some of those things that can come about. And I don't think that I understand some of it either sometimes because the renal arteries are open, and we see this even with dissection. There's no dissection into the renal arteries, and yet as you bring these people who have lived probably at this massive blood pressure for so long, they start to get that dysfunction. I don't know if you have any other thoughts on that.
No, that's exactly it. I mean, we see that all the time in this population because these are people that have been living in controlled hypertension for probably years. And we bring them in and we're putting them on, esmolol drips and stuff like that. And, I mean, anyone who's done an IC rotation understands that esmolol is a great medication for impulse control, but it's very high volume. You're giving these people a lot of volume by keeping them on an esmolol drip. So that's the flooding that you're getting. You're getting a lot of extra volume in place, and so you have very low ability to manipulate their volume status when you have one medication like esmolol. So we usually now have transitioned to other medications or multiple medications instead of just one to help control blood pressure and heart rate. But we've had issues where we have renal dysfunction develop. We've had people develop water strokes. We've had all sorts of bad outcomes from aggressive blood pressure control. So we've become, in recent years, a little more liberal with our blood pressure control. And we're not going so much for the 120 over 80 with a heart rate under 80. We're trying to be tailored to the individual, what they came in with, and dropping them slowly to get them under control until symptoms are controlled. So we're not going for absolute numbers anymore. We're going for symptom control, at least here.
No, I think that's something people don't talk enough about because as you go to these places and they just, or you read the book or you're, bringing some of that out. We have a protocol that deals with these aortic emergencies, which starts on one oral medication and then you bump it up and, multiple IV medications. But on one recent patient, we were so far, we'd given them everything on the protocol. Now we're pulling out new medications and pulling out data to add a fourth or fifth oral agent to our protocol, because what happens whenever you have them on all of this stuff and still you're in all of the oral agents, and that is, like I mentioned, that's pushing us sometimes to just say, okay, we're going to go treat this person. We're going to have to suck it up a little bit. We'll wait maybe 14 days if we can to kind of get out of that window, and then we're just going to need to treat this. So
Yeah, and it just goes to show that there is such an important conversation that has to be had, and communication has to be had between your ICU team and the vascular team managing this. There has to be open lines of communication. I know a lot of places have gone to a closed ICU system, but that doesn't mean that we are completely devoid of responsibility in the situation. So we have to be active participants in their care, which is what they do.
Do you think about IMH and dissections differently when you're talking about your anti-impulse control?
So yes, our group, we do think about them differently. We feel like with IMH, we have potentially more time, but IMH, we are much more worried about than dissection, to be perfectly honest. Dissection, I think we understand a little bit better than IMH, so I think we're less fearful about dissection. So if someone comes in with an acute dissection and alpha fusion, we're treating them. We're doing something interventional. With IMH, we're still not totally sure when the right timing is. because we've seen catastrophes occur from early interventions for IMH. And it's just that the aorta is completely unstable, much more so than a dissection, at least in my experience.
What is your strategy for coverage for TVAR for IMH? Do you cover the entire length of the IMH or do you cover the tear?
A great question. A lot of times you can't tell where the tear is until it kind of blossoms a few days later. And then you can see where the entry tear is. So our experience is we cover proximal from healthy aorta down to typically the celiac. And so we'll do extensive coverage for IMH, depending on how deep it is. But we usually won't go beyond the celiac at the initial goal.
Yeah, our goal is usually to try to get from healthy aorta to healthy aorta. And so it sometimes you can't just as it extends further down. But all right, well, thank you everybody for such a great conversation on this. Dr. Lee, you want to move us forward?
All right, next we will invite Cooper University, Dr. McMacken, if you want to take it away with the next paper.
Absolutely. Thank you so much. Let me share my screen. All right. Are you guys seeing this one?
We are.
Perfect. So I'm Catherine McMack, and I'll be talking about some of the background for chronic mesenteric ischemia. And my resident, Javier Arana, will be presenting this wonderful paper. Chronic mesenteric ischemia is the atherosclerotic stenosis and occlusion of the mesenteric arteries leading to hypoperfusion. Our classic features: postprandial abdominal pain, food fear, progressive weight loss. In patients who have diffuse disease, usually you need 2 vessels in order to actually become symptomatic. And untreated CMI can lead to risk of malnutrition and can progress to acute mesenteric ischemia with acute bowel infarction. The mainstay of treatment is stenting. You can see a celiac and SMA stent here, but there are a variety of mesenteric bypasses that can be done. The inflow can either come from your iliac or your aorta itself. And you can see here a couple different ways that the bypasses can come. This one is aorta to celiac and SMA coming retropancreatic. There are practice guidelines. These came out in 2021, and the senior author from our paper is actually the first author of the chronic mesenteric ischemia clinical practice guidelines from the SVS. So he is one of the experts in the country from multiple different areas looking at this disease. And their recommendations for treatment really provide the endo first option and then open as the second option. But they do always start with, it's really about a shared decision-making practice between yourself and the patient, depending on their goals. They don't, however, in the clinical practice guidelines, go into some of the nuances for open surgery and all of the different decision-making that goes into open surgery once you're in there, which is really what goes on in this paper. Now, planning on confirming my own bias that now we don't do nearly as much of this as we used to, I went and I pulled the ACGME case logs for last year and then went back a decade. And it turns out this is rare now, and it was rare a decade ago. There's actually a 0.2 difference in the number of cases between now, both on the fellow level and the resident level. And then thinking, well, maybe it's just a recent thing. I went back 20 years with the fellows. There's no actually resident data, but this was also 3.4 20 years ago. So these continue to be rare cases. It's why this paper is so wonderful, because it gives us a little bit more technical information and outcomes data just within the open mesenteric bypass subset. So Javi, I'm going to stop sharing my screen and I'm going to have you take over.
All right. Well, thank you so much for that introduction. Let me start sharing my screen. It's giving me issue. Here we go. Okay. Sorry, having some technical difficulties for sharing. All right, can you see this now?
We can. It's coming up.
All right, perfect. So as Dr. McMacken said, my name is Javier Arana. I'm a current PGY2 integrated resident over at Cooper University Hospital. Today I'll be presenting on the outcomes of open bypass and SMA endarterectomy for patients with CMI resulting from long segment SMA occlusive disease. This is a paper by Faisler et al. Out of the University of Florida. We have no disclosures to discuss. I won't belabor the point of the background in CMI, but things I do want to emphasize on is that the SVS guidelines do employ a endovascular first approach, but sometimes that's not the most ideal approach, specifically, especially for patients that have heavily calcific osteolesions, flush osteolesions, as well as prior stents that have gone down. And then you occasionally have to consider the more rare younger patient that needs a more definitive repair. Although endovascular repairs have great short-term results, at 5 years, the patency rates do approach around 40%, whereas bypasses stay open to about 90%. And so once you have a open repair, it kind of gives you possibly a more durable long-term repair, as well as a small subset of these patients do present with diffuse SMA disease. This article defines that as disease that extends 4 centimeters past the ostium. And so once you get into that territory, you have to think about a long covered stent, which adds the concern for your distal landing zone, as well as possibly taking out some collaterals. So that remains important to consider when you're having your toolbox the open mesenteric bypass, which comes with its own assortment of challenges. But this paper is really great for comparing those two or those outcomes. So the objective of this paper was to evaluate the outcomes of mesenteric bypass with and without endarterectomy and CMI. The primary endpoint was 30-day mortality, with the secondary endpoints being complications, reinterventions, symptom recurrence, and overall survival. The aim was to kind of help inform the decision-making in these patients with long segment disease and those requiring open revascularization. This was a single-center retrospective cohort analysis. Like I said, it was out of the University of Florida, and the way they performed it was that they took all the CPT codes for patients that were undergoing a mesenteric thromboendarterectomy, as well as a mesenteric bypass from January of 2002 to April of 2024. And then they further stratified this into a bypass alone group versus bypass with endarterectomy. And this was done based on the CTA and the suitability of the target vessel from their intraoperative findings. The exclusion criteria utilized for this study was that patients that underwent revascularization secondary to acute mesenteric ischemia were excluded, as well as those with mesenteric dissection, either in the isolated fashion or with concomitant aortic dissection. Those that underwent the more traditional transaortic endarterectomy were also excluded, and then those that underwent a ROMS. So for the demographics of the study, there was a total of 166 patients, that of which 83% underwent mesenteric bypass alone, whereas 17 underwent bypass with their endarterectomy. Overall, the demographics were widely similar. And then once you start getting into the cardiovascular risk factors, they were once again similar, but there actually was a statistically significant difference where there was more PAD and CHF in the bypass alone cohort, and there was actually less end-stage kidney disease in the bypass alone cohort when compared to the endarterectomy group. And then something that wasn't significant, but that I found interesting, was that although there was no difference in prior mesenteric interventions, up to a quarter of all the patients had a prior mesenteric stent. Getting into a little bit more of the nitty-gritty operative details, the bypass configuration either varied from antegrade, retrograde, or with a concomitant celiac bypass. And something that I really want to touch on is that there was a much higher percentage of the patients with bypass alone undergoing a concomitant celiac axis revascularization. And then this just happened to be more in the antegrade fashion, whereas the bypass conduit varied as well. The bypass alone cohort had more Dacron, where the bypass with endarterectomy used more PTFE. Once you're talking about the actual endarterectomy details, more than half used just a long spatulated hood alone. And then those that did undergo patch and arterioplasty, which was about 43%, they had a completely even split versus using autogenous vein versus a biologic. And then for the total number of blood products used in resuscitation intraoperatively, there actually was a difference between the two cohorts. The endarterectomy group had 3, whereas the bypass alone only had 1, which kind of goes in hand with the increased complexity of the case. But what was really interesting and touched on in the paper was that for the first 24 hours, resuscitation remained the same. And then the operative duration, although it was longer in the endarterectomy group, it was not significantly different. So once we start getting into the actual outcomes of the study, the primary outcome was the 30-day mortality, which showed no difference between the two groups. Bypass alone was only 3%, where endarterectomy was 4%. Median length of stay was the same in both groups, 11 days, and ICU length of stay was pretty much similar at 6 and 5 days, respectively. One of the things that the paper touched on was the complications, and both major and minor complications added up to about 53% for both groups. But I believe it was the bypass alone was 54%, and the bypass with endarterectomy was about 46. But this includes both major and minor, as you can see from the graphic. And then they also touch on the discharge disposition, where there was no difference for any of these. Once we start getting into the post-operative outcomes, which is where I think you can really glean some of the major pearls from this study, because there's a paucity of data, the median follow-up was 2 years, and then the median time to death in the bypass alone was 1.44 years, where the endarterectomy group was nearly 2 years. This was not significantly different. But then the overall survival at 12 months was 86% and 89%, respectively, and 67% and 72% at 24 months. So that's honestly a pretty high overall survival rate for this high complex case. And then once you start talking about difference in loss of primary patency, this was very interesting. There was a significant difference in the freedom from loss of primary patency in the SMA with endarterectomy group, with 13%, which comes out to, I believe, 2 out of the 28 patients having lost their primary patency, and 0% of the patients with the bypass alone group. There was also a significant difference in median time to reintervention, with the bypass alone going from 1.2 years and bypass with endarterectomy being 0.03 years. And then symptom recurrence, which was actually really impressive, was that there was only 8 and 4% symptom recurrence amongst these patients, and that was not statistically significant. And then readmission rates were 10% and 11%. Once again, this Kaplan-Meier just kind of goes over what I just discussed. But then when they performed a propensity matched analysis that took into account patient age and comorbidities, that significant difference in patency rates actually goes away. So I think the big takeaways from this study is that despite a significantly shorter time to reintervention in those that needed a reintervention in the endarterectomy group, the patency rates at 1 year remain above 90%, and there's no difference in symptom recurrence. So this kind of highlights that an open mesenteric bypass with an SMA endarterectomy is safe and effective for those select complex SMA occlusive disease cases without an increase in perioperative mortality, complication rates, or long-term survival, despite the added complexity. And then things that I just was thinking about and that are actually talked about in the paper is that the resources required in the post-operative period for these patients is very, very intense. These patients, all of them went to a vascular-specific ICU. Obviously, they received fantastic care. It's a quaternary center that see a lot of these patients and have a lot of experience treating these patients, which might not be generalizable to the rest of the country. And then another thing touched on is that study mortality was actually more closely associated with comorbidities rather than the procedure complexity. And then some of the limitations that were touched on by the paper were that I already mentioned all the cases being performed at the quaternary center, and then that the overall cohort size is modest, and there was a relatively short follow-up, 2 years, but overall it's still a fantastic paper and has a lot of these complex patients, which you don't see too much data on, and when you do a literature review, which is really interesting. And that's all.
So, is it me now? Okay.
Yes.
Well, okay, great. First of all, I'd like to thank you for the kind invitation. It's a real pleasure and honor to be a moderator in club. It's a great paper, and obviously, very few centers in the United States and around the world can produce such a paper. And the reason for that is that obviously it's a center of excellence. But even in your center, I noticed that you have 168 patients over a period of 22 years. So that's about 7 or 8 patients a year. Obviously that's not a big there's not many of these patients anyway. But if we consider the fact that you're in a center of excellence or a referral center, and this number is relatively small. I mean, most peripheral centers probably will never see such a patient, or they will refer them. That's my first comment. The second comment is that I'm not sure that the younger generations have that much experience in open surgery. So, because of the endovascular revolution, about 95% of operations are endovascular now, and I'm not really sure that these results will be reproducible in the future. I don't think that. Well, there are several papers that mention that the young generation don't have experience in open vascular surgery, so this is a very, very big surgery, and you need to be very experienced to perform it. I'm not sure these results will be reproducible in the future. And the third comment that I had is that you mentioned that the endovascular interventions have about 40% patency in 5 years, whereas the open surgery has about 90% patency in 5 years. The issue is that 1/3 of these patients didn't make it to 2 years, and I'm not sure how many of these patients will make it to 5 years. So it doesn't. If their bypass is open but the patient is not alive, I'm not sure it's really very helpful. So because of these patients have a lot of comorbidities and they're very frail, and they're very, BMI is below 20 sometimes, and they have loads of problems. I'm not sure that many of them would be very happy long term with such a big operation, and this is also demonstrated by your results, as I said. That's my initial comments. If you would like to answer some of them, please.
Yeah, I can take most of those. Tom Huber, I'm the senior author on this, and Mike Baxter, one of our trainees, is on board. Our experience, it seems like our numbers are higher. I know it's a 20-year experience, but I would say more recently on an annual basis, we probably do 15 to 20 mesenteric bypasses. We practice in the state of Florida. It is the world's greatest place to practice. The state of Florida has 25 million or 23 million people. We're the third largest state, and we're really underserved for vascular care. And so a lot of these really complex problems will end up at our institution. Fortunate for us, but at least our more recent numbers seem larger than we've reported. It's disheartening, of course, that the newest generation is less competent in open procedures. I'm at the end of my career. This is what I grew up on, and I had to relearn most of the endovascular things, as my cohort probably would all attest to. But we've kind of swung back, and now an open skill set is a good one, at least at the tail end of your career, because we're under training people. So yes, that's disheartening, but it kind of is what it is. I think it kind of echoes or underscores or underlies the fact that they should probably be concentrated in centers of excellence that have a lot of experiences. And now our results are good, at least on a mortality level. These are hugely resource intensive. The complication rate is every bit of 50%. The length of stay is probably in the 10 to 15 range. So they're hugely resource intensive. A good chunk of the people go to a facility. And I have to smile because the reason these patients have good outcomes is because we have a good care delivery system. Yeah, I know how to do this operation. I'm efficient at it and facile at it. But at the same time, we have great trainees. We have our own ICU. We have an anesthesia team that's dedicated and geared up for these type of problems. So our results look good, but it's because we practice in a center that allows us to provide good results as a kind of a larger team approach. In terms of longer term follow-up and mortality, it's interesting, we, like others, have published that it's not an open endo question in terms of mortality, it's a comorbidity problem. So, how well these people do long term often reflects their underlying comorbidities, not so much the choice of treatment. When we wrote the clinical practice guidelines, we had a systematic review that looked at open versus endo in terms of the optimal choice. And as you might guess, the mortality rates of both the short-term or long-term are pretty comparable. The complication rate was much higher in the endo, and the reintervention rate, the complication rate perioperatively was much higher in the open, but the reintervention rate was higher in the endo. So, like everyone else, our approach is an endo first if it's an option. I think we have a lower threshold perhaps than most people for doing open repair. But, it's, long segment disease, flush occlusions, severely or circumferentially calcified lesions that are less amenable to a stent and failed stents. And there's probably a small cohort of younger, healthy people that might do better with an open repair, although I agree that's somewhat debatable.
All right, great. There are some questions from before. One's from San Seattle. Normally you do a supraciliac clamping, right?
We see view the antegrade and
Or you do the
retrograde.
Sadisky clamp, or do you do partial clamping or complete clamping?
Two steps back. So, at least for treating chronic mesenteric ischemia, I would say the retrograde and the antegrade bypasses are complementary. We just had a paper at the Southern Vascular last month looking at just that, our experience, and we lumped it together, the University of Kentucky's experience. And there's really no difference in perioperative or longer term outcomes, whether you use an antegrade bypass or a retrograde bypass. And that our guidelines and the European guidelines have kind of suggested the same. Our group tends to favor the antegrade bypass. Often that supraceliac aorta is spared in terms of a lot of occlusive disease. And when we do it, we tend to use a partial occluding clamp. I like that the adult Satinsky clamp is actually shaped nice, and the handle kind of gets out of your way as you put it on that supraceliac aorta. We have a modified Lambert K clamp that has it's more of a hook shape, and we have a ratchet that we've had the machinist actually make that locks the tips. So one of the problems with that Lambert K clamp, it's not tight enough oftentimes to completely occlude that supraceliac aorta, and we have this locking tip mechanism. So we try to do a partial occluding clamp with either one of those two. If for some reason it's too calcified, you probably shouldn't be doing it. But if you find yourself starting on it, it's too calcified and you can't get a good seal, I will actually take a Kelly clamp, quite frankly, and lock down the tips of the Satinsky. But you can also use a completely occluding clamp, a Fogarty clamp if it's too calcified up top, and then a straight aortic clamp below, and just do a longitudinal arteriotomy. The anastomose itself is 15 minutes regardless, so it's relatively well tolerated if you have to occlude the aorta completely.
Okay, great. There's a question from Phil, from Dr. Benjamin Lee. How do you select patients who need endarterectomy versus just bypass?
Yeah, I think what we were trying to say is that, these long segment disease patients are a relatively small cohort. If you think about who gets an open bypass, not too many people, and who gets a long segment endarterectomy, that's even a much smaller. But in our practices, you'll see that patient with a 4 or 5 centimeter SMA occlusive disease. Most patients with mesenteric ischemia have orificial disease. That's why stenting works so well. But there is a small subset of patients that have that atherosclerotic disease that extends on into the third and fourth order branches, or the third and fourth branches on the SMA. And the question is what to do about that. And that's what we were trying to convey. I think there's a reasonable surgical option in that group of people. And it's, most recently we've done just a large vein patch, occlude proximally, occlude distally, and do a long segment saphenous vein patch, and then take the bypass graft onto that vein patch.
Yes. Okay, I read it in your paper as well. So you use vein, right? You use saphenous vein.
And the experience is pretty long. I think earlier on we were using a long hood. If you're doing an antegrade or retrograde bypass, you can have a very long hood of your bypass graft, kind of like you would do for a common femoral and profunda endarterectomy. More recently, in the last 5 years or 8 years, we've gone to mostly saphenous vein. You can use bovine patch, but in my heart of hearts, I think a saphenous vein is the best patch that we have available. It's a little tedious to dissect. The thigh complications are modest, but if you run through all that, I think it's probably the best long-term outcome, and that's our preferred choice.
One last question, probably from Dr. Hingorani. He prefers bypass and says, when did you introduce endarterectomy in your series? Like bypass is faster, less blood loss, and good results. And what was the criterion for introducing an
Yeah,
endarterectomy?
no,
Suppose it was a long operation.
I would not see them. It's not I don't see it as an and or. I see this as these are people that have long segment disease that the treatments are probably nothing, or SMA endarterectomy with patch and a bypass. The people that traditionally get bypasses have more proximal disease. That we're talking about that thing that goes, the average length of the patch is 4 centimeters or thereabouts. So it's a relatively long segment of disease. When I was a trainee, we did a case report that we presented to the Southern of this type of things. We thought, oh my gosh, it's so novel. But in this day and age, when everyone gets a CT, I mean, in our place, if you get constipated, you get a CT scan. So we're picking up a lot more of these lesions, and then we're forced to decide what we're going to do about them. I think historically we have said, I don't know, that's probably not reconstructible. In this day and age, I would say, yes, it's probably reconstructible in the right scenario.
Tom, do you
Yeah.
mind if I ask you a little bit about perhaps the phenotype between these two different groups? If you look at it for you did more sort of retrograde bypasses in the endarterectomy group, and on the other side where you're just doing bypass, you're using a little bit more antegrade. Perhaps, and we don't know a lot of this yet about the phenotype of different patients with peripheral artery disease or any type of occlusive disease. Is it possible that these patients have different kind of makeup of their plaque in certain ways, and that's why it presents differently? And as we get a little bit more data on all of that, we might be able to see that or predict this a little bit better.
Yeah, I'm not certain I could tell you that, and only because we viewed the antegrade retrograde as complementary. So, and the choice of that configuration is really often dictated by other things. Supraceliac aorta is calcified, or the iliac system is calcified, so that would preclude one or the other. If everything was equal, I like to do those antegrade bypasses. It's a nice operation. You can rationalize it. It's an antegrade direction. Maybe it's more difficult up front, but the patency rates are maybe better. That's probably not true. We've shown that, and other people have shown that. I think there's a bit of a UF bias that we tend to do that. I think there has been a change in the phenotype of people that we see with chronic mesenteric ischemia. I used to joke that, how do you know your grandmother's your grandmother? Because she's your grandmother. And I used to say, how do you know someone has mesenteric ischemia? Because it's that middle-aged woman that's a huge smoker and weighs about 100 pounds. But I think that phenotype has morphed with the epidemic of obesity. We're seeing a lot of morbidly obese or heavy people that have mesenteric ischemia. And the Northwestern group reported that a few years ago, and up to 25 or 30% of their practice of patients with mesenteric ischemia were actually overweight or obese. So they're changing in terms of, can I identify this group in this phenotype? I don't think we have enough experience or knowledge yet.
And then I'd love for you to give some tips and tricks for some of the young people. As we discussed, there aren't a lot of these. So things that you've changed just in terms of technique over the years, or things that you might remember in the back of your head that sometimes isn't obvious to everyone.
Yeah, I think for at least the endarterectomies, as most of them we do antegrade. So assuming that we're doing an antegrade bypass, we've kind of gone using a midline incision. I've used midline or bilateral subcostals. All the exposure that we want is in the midline. So I hate closing that bilateral subcostal incision. I like doing the midline, so it's a heck of a lot easier. And I dissect out the SMA first. They just mobilize. They've kind of approached the SMA in different ways, gone below the pancreas, pulled up the transverse mesocolon, or just mobilized the ligament of Treitz. And I think the most efficient, at least for me, is to just mobilize the ligament of Treitz. And once you take down the ligament of Treitz, the SMA is sitting right there adjacent to it. And for the patients that need the long segment endarterectomy, I'll focus on that first. And we tend to use these little red vessel loops on the branches. If I had to give one technical point, I would say use those tiny little red vessel loops. They are so atraumatic on the vessels. Over time, we used to use 2O silks as a POTS tie, and those are a bear because those little branches on the SMA, they're easy to tear. And then you create a big mess for yourself. The patients that need endarterectomy. I'll do the endarterectomy next. We'll expose the SMA and then do the endarterectomy. And I think it has to do with really being more efficient and repositioning the retractors fewer times. So we'll dissect out the SMA, put the vessel loops on all the branches, then harvest the saphenous vein and anticoagulate the patient and literally do the endarterectomy and vein patch right there. And then we'll start the tunnel behind the pancreas. I always complain to the trainees that every time I do that, I tell them I hate making tunnels because there's nothing good that comes from making the tunnels. But we kind of gently pass that thing retropancreatic, usually index finger on one hand to start it out. And then after we do the dissection up top, and so after we get out the SMA, I will reposition the retractors, and I use the Bucky. And when we submitted this paper for review, someone criticized us for using the Buckwalter retractor, and I said, if you come to UF, I can show you how to do it. So the Bucky, at least in my generation, is what we use, and you just get more efficient with it. And everyone has their own retractor system, and you work out all the steps, and that's what we tend to use. When we do the integrate bypass, it's to the common hepatic. So after we expose the SMA, we'll go after the common hepatic. Going after the celiac, it can be done, but it's a heck of a lot of work to dissect the base of that celiac. So we tend to get the common hepatic proximal to the gastroduodenal. And then the third step is to take down the crew of the diaphragm and then expose that supraceliac aorta. And I tend to put an umbilical tape around the supraceliac aorta just as a pair of suspenders. If you got into trouble, you could pull up on that and reposition your clamp kind of as necessary. And then we kind of go backwards, do the supraceliac aorta, do the hepatic, and then take that limb behind the pancreas to do the SMA anastomosis.
It's just that easy, huh?
Yeah. Well, it's very doable. It's well within all our skill sets, and I think what sets us apart perhaps is not me, but it's the care delivery system.
Well, thank you. And thank you for the great conversation and going over a lot of things with us. I think this was a great event. We want to thank our author guests for being here. That's always really important for addressing questions. And also our moderators for going over everything. KJ, thank you for joining us from the conference that you're out, and all of our other speakers and presenters. Dr. Mackin, also thank you for joining us. We will be back in March. We'll be back on March 11th at 6 p.m. You can register at the same place that you registered before, and have a wonderful night.
All right, strong work. Thank you.